ये रहा ना जूम इंजिन इसमें कौन करूँ? हेलो। नहीं, ये साइड के आ रहे हैं ना, ये फुल स्क्रीन कैसे है? तो फुल स्क्रीन तो पीडीएफ है ना ये तो फुल स्क्रीन तो छोड़ो, छोड़ो इसको स्टॉप कर दो, रोको ना, छोड़ो। एक मिनट, एक मिनट स्टॉप। क्या ये पूरा पोस्ट लेके आना चाह रहे हो? हाँ, वो उसमें उसमें है ना, मजा नहीं आ रहा, इनका चेहरा आ रहा, वेन्यू आ रहा, कुछ आएंगे, इसलिए मत करो, ज्यादा अच्छा है ना। आगे, कैसे ठीक है? हाँ तो गया, बहुत बढ़िया। क्या करना चाह रहे हो अब इसके साथ? अब इसको शेयर कर देते हैं, यहाँ एडवांस में जाओ, बैकग्राउंड लगाओ। बैकग्राउंड नहीं लगाना, बैकग्राउंड नहीं लगा, ये सिर्फ दिखाना है हमको बस, ठीक। तो शेयर कर दो इसमें, है ना, अब ठीक लगा, क्या बहुत आ रहा है, ये तो हट जाएगा, क्लिक कर ये वो तो हट जाएगा, अब ठीक लगा। कितने लोग अचानक कहेंगे? एक मैं हूँ, दो मैं हूँ, एक गेस्ट है, तीन लोग हैं, बाकी तो कोई दिख नहीं रहा है। देखो ना रूम में, ये अभी इसको अपन ने शेयर किया है, ठीक है जे आप स्क्रीन पे आप बोलिए शेयर है ये आपकी मैंने स्क्रीन में दिख रही है, वहां दिख रही है ना, आपके जो स्पीकर है वो देख पा रहे हैं इस पे, ठीक है। अब आप बोलेंगे तो आपकी वॉइस भी जाएगी और आपकी पिक भी जाएगी। अभी ये मैंने थोड़ा सा ये कम कर दिया, ये देखो ये मैं आ गया, ये आपके सर का वीडियो ऑन नहीं है, ठीक। हाँ कुछ लीजिए, शुरू करना है। ये वाले ऑन करना है। The video is on from our हाँ वही। Good afternoon, everyone. I would like to welcome you all to today's online lecture on personality disorders, issues, and challenges. I would like to call Dr. Navrathan Sir to give a welcome note and say a few words on today's program.
My humble pranam to all of you. The speaker of the day, Dr. Akash Kumar Mahato, my esteemed colleagues, dear students, today we have gathered here for this online guest lecture. And the theme, the topic selected by AIBHAS through the coordinator of the event, Professor Rajendra Kumar. Personality disorders, issues and challenges. I formally, heartily welcome you all in this guest lecture. And purpose of these guest lecture are to enrich our knowledge by listening to the speaker and by interacting with the speaker. So whatever your point of view, whatever you understand, wherever you have certain queries, please note down. After the talk, you can come here on the stage and you can have your question with the expert. Dr. Akash, you are getting us?
Yes, sir.
Fine. You can see us?
Yes, sir. Perfect.
Okay. I extend welcome to you, sir.
Thank you, sir. Thank you so much.
Hopefully, very soon we may interact physically also.
Sure, sir. That will be our pleasure.
So, personality disorder, I am not that much well acquainted with the clinical psychology terminology, but I understand that when there is something which is not in order, maybe the disorder. And personality, when we understand that it is our outer as well as inner. And if this is in disorder, you can imagine how our conduct, how our daily routine life is going to be affected. So I'm very keen to understand this concept. I am very keen to understand that how personality disorders, particularly for those students who are pursuing here RCI courses, these disorders also trouble the therapist because they have their different kind of orientations, and those orientations you need to resolve without taking more time between you and the speaker. I again welcome you all and appeal that you must take the full advantage of today's lecture. All the best.
I would now like to call Dr. Rajendra Sharma to highlight objectives of today's topic.
Good afternoon to all, and respected our resource person, director sir, and all in all. When we had discussion about the topic while we received for guest lecture early, and when we received that I'm supposed to have this guest lecture, we were very happy that we took personality disorder issues and challenges because since beginning of the even though ICD classificatory system or the DSM since 4 to 5 TR, this is the disorder, this is the condition which has a lot of chaotic situation. While we are going to have any diagnostic impression, this makes very hurdles because itself in a generic way, this disorder has overlap conditions. So I think we plan that we will have this personality disorder issues and challenges for our today's session because we will learn how to understand these things and in all the courses RCI, MPhil, PDCP, PGDRP, even though the M masters, everywhere this content is there. So I believe that this topic would be very enlightening and learning. So I will not take much time and will proceed further. Thank you so much.
Now I would like to introduce our esteemed speaker for today, Dr. Akash Mahato. Dr. Akash Mahato is an associate professor in clinical psychology and head of institute at Amity Institute of Behavioral Health and Allied Sciences, Amity University, Kolkata. Having done his MPhil and PhD in clinical psychology from Ranchi Institute of Neuropsychiatry and Allied Sciences, Dr. Mahato has experience of over 20 years in industry and academia. He has contributed as principal at Spikar Academy of Rehabilitation Sciences, Secunderabad. He has also contributed as faculty and clinical psychologist in postgraduate teaching departments in medical colleges and universities in the past, including LGP Regional Institute of Mental Health, Assam, Amity University, Jaipur, and Gandaki Medical College, Nepal. His interest areas lie in evidence-based psychotherapy, therapeutic indication of neurocognitive functions, and community mental health. Dr. Mahato is panel member for syllabus revision examination for postgraduate programs at prestigious institutes, including IIT Palakkad, Rashtriya Raksha University, Ahmedabad, SRM University, Chennai, Osmania University, Hyderabad, and West Bengal University of Health Sciences, Kolkata. He has co-edited the book Mental Health in Aging and has over 60 peer-reviewed national and international publications to his credit. We welcome you, sir. Now, with the permission of Director, sir, I would like to begin today's guest lecture. Over to you, sir.
Thank you, ma'am. A very good afternoon to all the esteemed faculty members of Amity University Warrior. And at the outset, I would like to thank Professor Dr. Navratna Sharma, Director of AIBHAS, Amity University Warrior, for giving me this opportunity to speak on personality disorders. I would also like to thank Dr. Rajendra Sharma, with whom I've been closely associated for last 15 to 20 years. And when he proposed me to speak on this topic, I asked like, what exactly you people need? Because I know Amity Gwalior is doing really well in the domain of clinical psychology. You people have a very good department in the clinical psychology, running MPhil and diploma programs and also BSc clinical psychology. So we thought of going more into applied mode, not discussing much on the theories. And I would like to focus more on the applied aspects of personality disorders. What are the finances when we deal with patients with personality disorder? So without wasting much of time, I would like to start share my slide. Please let me know if it is visible to you. Is the slide visible to all of us? Is the slide visible? Can anyone confirm?
Yes, sir, the slides are visible and audible.
Okay. And I am audible?
Yes, sir.
Okay, thank you. So when we're talking about personality disorders, so I very much remember that when we were in our training days, our consultant or the like our teachers used to ask like, what are the most difficult conditions to treat when we are talking in terms of psychiatric illnesses or mental health conditions. So the two most dreaded conditions which we discussed about was, first of all, substance abuse, in that most typically alcohol dependence, and second was definitely personality disorders. So the idea was, irrespective of whatever you do, whatever approach you take, or how much effort you take, these are the two conditions in which you are getting invariably some kind of relapse or rebound of the symptoms. And typically you will find the overall outcome of these conditions, whether they are treated or not, this is a very poor treatment outcome. So why this poor treatment outcome is happening? And mostly this is being attributed to the high heterogeneity of the symptoms and the complex presentation they come up with. So I'm talking mostly about the personality disorders. And typically, personality disorders, it has always been a complex condition. So it's not that there is something very new issues emerging in personality disorders or new challenges. Challenges has always been there. But in recent times, especially when we see there are some new emergence in the terms of classificatory system, post-COVID scenario, there is a lot of emergence of mental health conditions in young generation. There is a need to speak about, when we discuss about patients with personality disorders, we need to see this in a lighter perspective or in a broader perspective. So in my presentation, I would be trying to discuss my presentation in terms of what are the changes that has happened in classificatory system and how they have evolved and how they are affecting our impression of personality disorders in current context and how we need to adapt our knowledge regarding that, and whether the presentation of personality disorders has changed in recent times or not. Like we see a very huge kind of a diaspora of the way people are coming in OPDs or mental health clinics, and we see some kind of change, like the kind of presentation what they're coming up. This is a bit different what we have used to see conventionally, say like even 10 years or 15 years back. And what are the difficulties when we are trying to formulate these problems as a case. And I would like to discuss this with help of a case example, a real case example also. So I'll start with the overall evolution of the classificatory system in terms of personality disorders. Say, if you start with how personality disorders were like mentioned in the very first editions of the ICD, if you take the example of ICD-6 or ICD-7, which came in early 1950s, 1949 to be exact for ICD-6 and 1955 for ICD-7, we hardly get a very credible recognition of personality disorders, and they were not systematically classified over there. So it was a very loosely grouped categories. Example, they were mentioned as psychopathy or neurosis. So we didn't had a kind of classification which could say of in terms of personality disorders. By 1965, when ICD-8 came, there was the first attempt to include these personality disorders in a more structured format. And this was the first time when we could see terms like paranoid or schizoid or sociopathic, which could give some categorization of personality disorder, but still they were very descriptive and vague. And somehow the diagnostic criteria was also not very clear for these conditions. By 1977, things were relatively better, but again, I would say still there was a challenge in giving a structured diagnostic category. And we had a category or coding under the 301, and we have separate conditions like paranoid, personality disorder, schizoid, or explosive, hysterical, or anarchistic. But again, there is a difficulty in having a standardized criteria that what personality disorders are. The best part happened in 1992 when we got the second best edition of like the ICD-10. When it came, there was a major revision in terms of giving a detailed diagnostic guidelines for personality disorders. And what we were seeing that we have 10 categories of personality disorders, and they emphasized on the long-standing and maladaptive personality patterns or the traits, which included cultural considerations and differentiation from other disorders. But again, the criticism was there was high overlapping and there was very no clear distinction between how do we actually differentiate between the comorbid conditions, and these issues are still till date. Now in 2022, when the latest edition of ICD-11 has come, they have gone for a major change, like there's a paradigm shift in what ICD-10 was and what ICD-11 is. So now ICD-11 has made all the categories redundant. Now it is going for a single code of like personality disorders, and they are talking in terms of severity, in terms of mild, moderate, or severe. On top of that, they are given some trait specifiers that, okay, you can specify certain traits that this is an anarchistic or some kind of dysthymic, or there are 5 categories which we'll be discussing later on in this presentation. So if we see, just a moment. Yeah, this is the specification of personality disorders what was in ICD-10. So I would like to give word by word of this detailing. Especially for the students, I would like to ask, just take a note of this, what ICD-10 says and what ICD-11 says, and you will see a very fine difference between what ICD-10, how it has shifted from ICD-10 to ICD-11. So ICD-10 says it's a specific personality disorder is a severe disturbance in the characterological constitution and behavioral tendencies of the individual, usually involving several areas of the personality and nearly always associated with considerable personal and social disruption. It tends to appear in late adulthood or adolescence and continues to be manifest into adulthood. It is therefore unlikely that a diagnosis of PD will be appropriate before the age of 16 or 17 years. So please take a note of this and try to compare what ICD-11 says. Now, very contrastly, you see there is the overall elaboration of the PD or personality disorders is bit change and more elaborate in ICD-11. What it says, it is characterized by problems in functioning of aspects of the self, example, identity, self-worth, accuracy of self-view, self-direction, and or, this is very much important, it's not saying mandatorily both the things, it is making and or interpersonal dysfunction. That means interpersonal dysfunctions can be an option, not a mandatory thing. Example, ability to develop and maintain close and mutually satisfying relationships, ability to understand others' perspectives and to manage conflict in relationships that have persisted over an extended period of time. Example, 2 years or more. So anybody from the students group can highlight what is the most important difference they see, how the description of personality disorders has changed even to some minute extent from ICD-10 to ICD-11. Anyone? I think there are some issues with the mic, so I will continue on this. If we see the major contrast, if in ICD-10 to ICD-11, definitely the categorization or the description has become very elaborate, and you will see a major shift from category to dimension. So in ICD-11, they are trying to focus more on the dimensions of what characterizes personality disorders, and they are talking more about the functioning aspects of the person. Initially, what it was more about the disturbances in the constitution and behavioral tendencies of the individual, but here they are talking about the functioning aspects of the person in terms of identity, self-worth, accuracy, and self-view or self-direction. But it doesn't mean that ICD-10 is now redundant and we have to exactly go for ICD-11. ICD-11 still has just now been adopted and still is in a very nuanced phase. But we need to see why this change has been made. Now, this is very important that they are very much categorical in mentioning that disturbance is manifest in patterns of cognition, emotional experience, emotional expression and behavior that are maladaptive, and they are inflexible or poorly regulated. Again, one most important factor is that here you will not see the age specifier compared to ICD-10, where they are clearly mentioning, even though they are saying there could be exceptions, they're mentioning that it is inappropriate before the age of 16 or 17 years. Here, they are not specifying anything about the age criteria. So it is likely, it's not like it would be not a very wrong thing if we can diagnose a person of personality disorder even before the age of 18. But again, you need to be very careful if the person is actually meeting the criteria or not. So definitely the distress part is definitely there. It's not that they are totally renouncing the concept of distress in personality disorder, but somehow the focus has shifted more from the categorical approach to a dimensional approach, and they're trying to see more in terms of dimension what actually the constituent of personality disorder is, rather than blaming the person for that. So this is the listing of categories in ICD-11 compared to ICD-10. So in ICD-10, we all know, we all are from psychology background, so that the categories were paranoid personality disorders, schizoid, dissocial, emotionally unstable, the most famous ones including impulsive type and borderline type, histrionic, anancastic, and anxious avoidant, and dependent personality disorder. But now in ICD-11, which came into effect in 2022, the categories are simply in terms of mild, moderate, or severe. So we did not find any of these subtypes which was there in ICD-10. And further, we need to give a trait domain qualifiers like negative affectivity, detachment, dissociality, disinhibition, anancastia, or borderline pattern. So we need to categorize or give a trait qualifiers when we are going for a diagnosis of personality disorders as per ICD-11. Now, this might be confusing for the students, like those who are currently doing their MPhil or professional diploma in clinical psychology or even bachelor's in clinical psychology from the RCI affiliated programs. They might be confused. So, sir, what we shall follow right now? We shall go for ICD-10 or ICD-11 because this is just in infancy and many people do not know how it is going to affect the overall clinical practice as such. So many people, including people like us who are from kind of old school, we passed in 2005, we still prefer to go by ICD-10, but we need to understand that why this change has happened. So until unless we very quickly adapt to this change, it will be difficult for us to understand the psyche of the person who is coming to us for some kind of help. And it is it's good for us that we understand these nuances early as possible. Now we see a comparative of what the DSM has done. Like they have gone for a kind of smart play, kind of played safe on this. So they have retained both two kind of categories. Like they have retained the previous categorization of cluster A, cluster B, and cluster C, where cluster A was order eccentric, which included paranoid, schizoid, and schizotypal personality disorders. In cluster B, it was dramatic, antisocial, histrionic, narcissistic, and borderline. In cluster C, it was fearful or anxious, avoidant, dependent, and OCPD. But again, the issue was higher degree of overlapping, and there were a lot of contentions that that people do not had a consent on that they agreed on these. Now in DSM-5, which came in 2013, they have retained the same previous 10 categories of personality disorders, but alternatively they have introduced a alternative model of personality disorders, which is in short known as AMPD. And very similar to like the ICD-11, they are using 5 maladaptive trait domains, which are more or less similar than ICD-11, but bit different than ICD-11. So if you see, the domains are negative affectivity, detachment, antagonism, disinhibition, and psychotism. So if we look at a comparative of these, like people might be confused with like what is now in ICD-11 and what was in ICD-10. It's not that the whole gamut of personality disorders has changed. Things are the same. Even if the person who is coming with a diagnosis of personality disorder, the person is the same. The only way is the approach through which we are trying to understand the person and to understand his overall symptom presentation or the sign and symptoms of that person. So even now, if we talk about the trait specifiers in ICD-11, if you look at the first trait specifier, that is negative affectivity, which is mostly emotional instability or anxiety or mood swings or characterized by low self-esteem. So somehow we are trying to refer to a person who will be falling under the category of either emotionally unstable personality disorders or dependent or avoidant as per the ICD-10. If we talk about the detachment specifier, which is somehow indicating withdrawal from social interaction or emotional coldness, we are somehow trying to include people who could have been diagnosed with schizoid or avoidant as per ICD-10. If we talk about dissociality, we are trying to infer about disregard for others and lack of empathy and callousness, which is somehow corroborating with dissocial or the antisocial in the previous version of ICD-10, or narcissistic, although not formally listed in ICD-10, but it is clinically recognized. The fourth one is disinhibition, which is somehow inferring to impulsivity, recklessness, and lack of planning, which now corroborates to the previous description of emotionally unstable or impulsive type or dissocial type in the ICD-10. And when we talk of the fifth specifier of Anand Castilla, which is basically perfectionism, rigidity, control, and hyperorderliness, we are trying to somehow indicate about the obsessive compulsive personality disorder as per the ICD-10. So it's not a very rocket science as such, but we need to understand that we are trying to rather shift from a category to more than of a dimension. And it is very much possible that a person may have more than one specifier. It's not that a person will be having one specifier of negative affectivity or of detachment or dissociality or disinhibition or anesthesia. The person may have a combination of one or more than two specifiers the way initially we used to have. And people will agree that even when ICD-11 was not there, even then we used to diagnose people with say like personality disorder unspecified, or like we used to mention the presence of trait and not meeting the full-fledged criteria of personality disorders as such. So in that way, things are more or less same, but maybe we can say it's a more dimensional approach, trying to make things more simple to understand for both the professional as well as less stigmatized for the client and the individual. So as I said, like people might be confused that what to follow now, where we will follow ICD-10 or ICD-11, DSM-4, TR or DSM-5. The answer is none of them are redundant or none of them are like the fixed one that you should use only ICD-11 or DSM-5 only. People are free and they are free to use any of these, but the only idea is that you should be able to comprehensively justify or explain the overall symptomatology of the person, so that whatever you're writing in the report of the person, that actually reflects his or her personality or the pathology if the person is carrying as such. So there is no fault if you are still referring to ICD-10, but definitely because we are progressing, we need to adopt to what actually there is in ICD-11 or in DSM-5. So we should be aware of those. But even if you are using ICD-10, there is no harm in that. So this leads to another question, that why we are actually discussing about these issues or challenges, whether the overall symptom manifestation in personality disorders have changed across in last 15 to 20 years. Answer is yes. To a certain extent, there is a yes. If we see, try to explain in these contexts, like what are the cultural and societal shifts. We see that in recent times with the advent of social media, like say Instagram or Facebook, or there are many social media platforms, people have very easy access to express their emotional expressions, like what they are feeling. I am feeling good, it's on my Instagram page. I am feeling bad, it's on my Instagram page. I am eating this is on my. So everything is very much open, and people are very much open to express that what they are feeling at that very much point. They do not have the patience to wait, and they do not also have the inhibition to what to show and what not to show. So it has its own consequences, both good and bad. This is beyond the scope of this topic, but again, when they engage in these kind of activities, they have some associated issues which can come up in terms of emotional dysregulation or identity issues. That what actually I'm trying to show or what I'm trying to reflect, whether it is very much mandatory for me to show on the Facebook or the Instagram, otherwise I will be very much feeling empty at the end of the day. So that comes with a lot many issues. There is a changing norms or the blurring the line between the normal personality variation and disorder. So when people engage in certain behavior and they see that a similar kind of pattern is being seen by some of their classmates or their neighbors, they feel that, okay, this is a very normal behavior. But maybe that particular behavior deep down, say 10 or 15 years back, that may not be looked into a very good perspective. So the differentiation between a normal personality variation and the disorder is it's a very thin line difference. So what you call as a disorder, what you call as a personality variation, this is very difficult to see. And people nowadays are very much sensitive. If you call them, okay, no, you're not doing good, or this is not expected, they take it in a very different way. And people taking feedback it's a very challenging task to make them understand. Second thing is that overlap with other conditions. Initially, when we used to discuss about personality disorders, we typically used to think about suicidal attempts or depression or anxiety, or at most some kind of anxiety features as such. But now in recent times, as in the medical research has improved or it has progressed, we are seeing that there is a very high comorbidity or increasing data on how they are co-occurring with mood symptoms, with anxiety symptoms, very importantly with trauma-related symptoms and neurodevelopmental disorders, example ADHD or PTSD, and also in autism. It is a very common occurrence that you will see that in patients with milder forms of autism, or maybe which were the earlier category of Asperger's, they might be misdiagnosed with some kind of personality disorders. So it calls for a more trauma-informed and neurodiverse informed approaches. Like what we are trying to diagnose as personality disorder, we need to see that down the line, is there a underlying condition of ADHD or PTSD or autism, or is there some issues with mood condition or anxiety or not? So we need, whenever we're trying to see a patient of personality disorder, we need to see in a longitudinal perspective and not in a cross-sectional perspective. Second thing is the early recognition. People were initially very hesitant to speak about their condition, that I'm having these and that issues. But nowadays, people are very much open to speak about their conditions. And at times, it has also been observed that at some younger generation people, they feel proud to speak about these conditions also. So there is a more recognition of PD traits in adolescents, especially borderline personality disorder, earlier than traditionally diagnosed, which is previously diagnosed before, avoided before age of 18. So nowadays, even if the person is in the age of late 15 or 16 or 17, even then if they are meeting the criteria of borderline personality disorder, it might be safe to go for a diagnosis of borderline personality disorder. So there is a increasing trend in early recognition, and that's why there is a change in overall, I won't say in terms of prevalence rates, but definitely the pattern has changed to a certain extent. As I initially mentioned, the trauma-informed perspective. So personality disorders, especially BPD or the borderline personality disorders, are increasingly viewed through the lens of complex trauma and attachment issues, and not just fixed personality structure. So again, this is a focus on shifting from category to dimension of personality disorders. So like, it's not on kind of a onus doesn't lies only on the person that you are having issues with your coping skills, you are having issues with your defense mechanism, you are having issues with your resilience. Basically, we need to see that whether there is a history of some kind of complex trauma, or there is an issue of attachment which has happened, may have happened in the childhood. So it's not always in terms of personality structure. We also need to see in terms of the history also. Now, if you see in terms of media and technology influence, definitely as we speak in the previous slides, the advent of social media has given like a huge tool in the hands of especially the young adults and the adolescents. So it has increased the social media exposure, and it may amplify histrionic traits, identity diffusion, especially in BPD or validation seeking behavior. So maybe like if my classmate is doing this, and if I'm not doing this, maybe I'm somewhere I'm lagging back. So even I need to do that. So even if I do not like that, I need to do that. So people think of like getting a validation of their behavior. Online behavior may reflect or mask certain traits, example, avoidant or narcissistic traits. So a person who is typically avoidant, maybe he will be doing the same on online activities also. But a person who is narcissistic, it may or may not be reflecting exactly the same on what he or she is doing on his online behavior actually. So what a person is engaging in the online activity, that may or may not be very a true reflection of his or her personality traits. So when people are engaging in this, and when they get rewarded because of those behavior, they tend to engage on those behaviors and continue doing those, and in this they create a loop of a very vicious cycle, which is actually very detrimental to their mental health actually. So this is very important to understand that how and how much or when they will actually use the social media and for what. This is very much important to understand, especially for the younger generation. So the social media, online validation, and digital identities affect self-concept and interpersonal functioning of the young adults. So it is very much important to understand how much they are engaged in the social media. Many times, like we have a OPD like in our own campus. I'm sure you people must be also be having. So when people come up with these kind of problems, we, apart from taking a clinical history and like family history and personal history, we also take the history of what is the overall pattern of their social media engagement. So that also give a very good insight of what kind of engagement is there and how it is actually impacting their mental health. So social media is not always in a negative connotation, keep in mind, but definitely what is the pattern of your engagement in social media, that is important to be understood, especially in context of personality disorders, particularly in borderline personality disorders. So indulgence may intensify traits like narcissism, emotional instability, or detachment. Again, the major issue is also on the existing PD models are Western centric. So like whatever things we have developed, like definitely DSM has been kind of a leading the way, like whatever additions or whatever advancement in the categorization or the classification it has come, DSM always follows the lead. ICD being a global brand or kind of involving सबको लेके चलो, they come up with bit late, but definitely they are more comprehensive. So even then we have some kind of influence from the DSM also. And nowadays it is more kind of a interchangeable, like DSM is not trying to more compliant to ICD. ICD is trying to be more compliant with DSM. But still now, whatever existing models are, they are still very much Western centric. And we have very limited understanding of how this pathology for personality disorders, it is manifesting across cultures. We may agree mostly on the borderline personality disorder category, which because it is very much common in as such. But if you compare the other categories, there might not be very much exact commonality, and that's why you see the differences in the trait specifier which are now mentioned in the ICD-11 or the DSM-5. So the cultural differences are definitely there, and still there is a lot of understanding left how we are trying to understand personality disorders in terms of cross-cultural validation. So I will try to understand, like give this example of this is a very real case example which has came to our own OPD, and I will try to discuss this case and discuss with the students, especially if they can comment on what they make out of it. So this is a case of Miss SK. She is 22 years old, female, and a PG student studying in the engineering department of our university. And she was presented with this complaints of concerns with identity, like she has repeated like doubts, or like she overthinks or broods about, I don't know who I am, like what is the meaning of my existence. There are mood fluctuations within a day rapidly, and she struggles with consistency in completion of tasks, and she is very much having impulsive decision making, and she is fearful of being abandoned by significant others. There are history of self-harm, at times very frequent, at times she is on hold. Then there are interpersonal difficulties with her peers, and there is excessive use of cigarettes and unprescribed medication, which are like actually prescribed to her initially, but she is now overusing them without prescription. So these symptoms, the first set of symptoms are for last 13 to 14 years, and further in late adolescence. And for past 3 to 4 years, she is having use of cigarettes and unprescribed medication of tab ranitidine. So basically for her sleep issues, actually. Some of the core features of her history, I will not go in the detailing all of her history, but the major core of her problems were like that. She presented with concerns of questioning who she is, what are the traits that make her a person, and at times does not understand her role with significant others. And she said that I don't know who I am. So this feeling of like the crisis or the problem with the self-concept, this is coming up in the terms of questions like, I do not know who I am. She wakes up feeling nervous about existing. She reported waking up and wondering why I am alive. Her mood is reported to change during the day based on events occurring. Minor issues distress her, such as if one of her friends is rude to her, for the whole day she will be upset and thinking that she dislikes me now. And she finds it difficult to cope up with the same. So every time she has a fight or some kind of issue with any of her friends, she is in a very bad mood. Her energy to carry out tasks in the day is mood dependent. And if she feels content, she will do things okay. But if not, the whole day is like a haywire kind of thing for her. And in terms of completion of important assignment, she does, but at times she not able to meet the deadlines. And at times when there are some negative life events, some distressing things are happening, she is engaging in some kind of self-injurious behavior, mostly slashing her arms. So frequency is again fluctuating, as I mentioned in the beginning. So at times it is very frequent, at times it is on hold. And she is also having issues with her body image and dissatisfaction with her speech clarity and content, believing it is not intellectual. So like this is happening for last 13 to 14 years, and much of detail could not be elicited. Now, the important thing, like I said in the beginning, it is not important to reach the diagnosis. It is important to understand the person as a whole. So if you look at the background of this person, of this patient, if you look at her past illnesses, in class 7, she was diagnosed with childhood depression with sleep paralysis, and she is still on medication for that. In her bachelor's first year, she was diagnosed with bipolar affective disorder. So you see the change or the kind of stress she has gone from such an early stage, from childhood depression, now being changed to bipolar affective disorder. And by third year of her bachelor, she was hospitalized for 3 months in December 2023 and was diagnosed with schizoaffective disorder. So for a professional point of view, many times we are very much focused on giving a diagnosis, what is the diagnosis per se. But think from the perspective of a client, that from class 7, she is on medication, the medication any of us would be hesitant to like take, like the way we take paracetamol when we are having fever. We will hesitate even if it is being prescribed by a doctor actually. So think of this patient who has been under medication for such a long period. And again, if you look at this is not past illness, the family details. There is a history of substance abuse, mostly alcohol, in both parents as well as paternal and maternal uncles. So very heavy family genetic loading of substance dependence in both parents as well as first and second degree relatives. And many other family members are also having history of medication for depression and anxiety. Details were not available with us. So important thing is not that what is the diagnosis. We will be able to meet the diagnosis for this patient as okay, personality disorder, borderline personality disorder with this traits. But what actually we are looking for this patient. So there comes the categorical versus dimensional debate. So whatever changes that we have discussed in the previous slide, that ICD-10 to ICD-11, the idea was the same, that we are not looking at the convenience of reaching at the diagnosis, but looking at the dimensions of the person. So when we are assessing a case of personality disorder, what we are actually diagnosing? Are we assessing the core disorder, or are we assessing the comorbid conditions, or are we assessing the effects of the disorder, or are we assessing the environment as protector or the facilitator? So the answer is to yes to all of this. So that is what we are saying, that we are not looking at the category, but more as the dimension. Definitely category is important for in like professional reference as such. But again, when we are dealing with the client, it is not important what is mentioned in the report, but basically why the patient is like this, what we are seeing to him or her. So when we see these kind of patients, the history is often so long, so complicated. Patients try to explain the things in their own terms, often trying to portray them that this is not their fault, or maybe they have at times a guilt feeling or kind of thing, that this is not my fault, this is because of this and that. And many times the history here is very complicated. And this makes the overall diagnosis of personality disorders a very challenging task. So it is very much important that when we formulate a case of personality disorder, it is important to make a formulation that it explain each and every phenomenon, every pathology, every behavior of the patient to maximum possible extent. So this is why what we refer to the case formulation. It is the organizational framework for producing a narrative that explains the underlying mechanism and proposes hypothesis regarding action to facilitate the change. So we are not, definitely the diagnosis is important, but more important than that is that how we make a plan, that how we hypothesize that if we engage in this kind of therapeutic plan for this patient, this can lead to a positive change in the patient. So for that, it is very much important to understand the person in totality, not just to reach the diagnosis per se. So when we are talking about this formulation, so it is very much similar to what we refer to as the psychotherapeutic formulation also. So many of the things are very much clear to students who are from PG or MPhil background. Still, I would like to give a brief of this. So definitely presenting problem and chief complaints are important, not going into detail of this. But very much important is to identify the predisposing, the vulnerability and protective factors of the client. So we need to see that whether the problems what the client is mentioning, whether they are pervasive in nature or they are only situation specific, or it is happening with some specific people or some in some specific circumstances. So we need to see what are the predisposing, how much the patient is vulnerable, and in what other conditions the patient is not engaging. So that will give us an understanding that, okay, this is the overall pattern of the symptoms. Third is hypothesize about the mechanism whereby the interactions between these factors generate the chief complaints. So once we try to develop the pattern that, okay, this condition is, this typical behavior is happening only with person A, but not with person B, we may be able to generalize the, okay, this is not a pervasive condition, and this may be more of a situational and reactional thing. Then identify the development origins of the complaint. So we need to see from, as I said, the childhood history or the overall old history is very much important. That from how long, or if there was some specific triggers or not, those things are very much important to understand. Identify potential triggers, like what are the precipitating factors. Many times people say that they had a breakup with some of their friend, or they lost some of their job, or maybe they had some trauma, somebody in the family scolded him or her very badly. But you need to really understand that whether that is actually a trigger or not, because what the patient is saying, that is of his or her understanding, but clinically that is actually valid or not, that is a clinician task to validate. So it is more important to understand the signs rather than symptoms. Symptoms are what the patient is reporting. Signs is what the therapist or the professional is observing. So it is more important to focus more on the signs rather than the symptoms. Identify what is making this problem a persistent one, like what is maintaining these issues, like whether it is the approach of the family members of not supporting the patient, or is it the very negativistic attitude of the environment of the society which is maintaining these factors, or whatever it is. So we need to see that how and when these symptoms are being maintained, and if we can stop those, whether it can have a bearing on the continuity of these symptoms or not. If they are, we can stop, maybe they will be not in the purview of personality disorders. Then further, prepare hypothesis about the problem recurrence, interventions required, and anticipated obstacles to effective intervention. So maybe when we can highlight the most important, the priority focused behaviors of this person, maybe we can make a pattern. So nowadays, many apps have also come. Like in our days, you used to make a kind of a flow chart or some kind of a correlational kind of thing, that these are the important people, and in these conditions, the person is more prone to engage in this. But now certain apps are also available, and you can use them also, so that you can get a kind of a good validation or the kind of formulation of this patient to understand in which conditions the patient is more prone to engage in certain kind of maladaptive behavior, and make a therapeutic plan for that patient. So again, in all of these formulation, as I said, history is better than cross-sectional observation. Many times we are very much getting biased towards what we see on spot for the patient. Okay, this patient is having some kind of slash marks on his hand. Definitely he is a case of PD. Do not get biased. So history is better than cross-sectional observation. Again, recent history is better than ancient history. I'm not talking that to totally negate the ancient history, but again, we also need to understand in current recent times what has been the recent happening which has affected the patient's current behavior. Then collateral information augments history from the patient. So collect information from other family members or friends or relatives that will add value or validity to the history of the patient. As I said, signs are better than symptoms. So signs are like what we can clinically observe or measure. Symptoms is what the patient is reporting, and what it is his or her subjective experience. So there might be in a fault in what symptoms are being reported, but signs are a better judgment or a kind of a better parameter of assessing a person if we are dealing with a patient with personality disorder. And I said, objective assessment are better than subjective judgments. Many times clinicians are often driven by our own biases. So do not get driven by your own bias, and try to take help of objective bias. But again, simply because if a person is scoring high on certain scale or some kind of screening, do not go blindly for a diagnosis of any personality disorders. Our clinical judgment is very much important, but definitely we need to corroborate both our objective as well as subjective judgments. Further, try to explain all the symptoms with the fewest diagnosis possible. At times, we tend to make multiple kind of things because we ourselves are not very confident. He or she is having traits of BPD, with symptoms of anxiety, with symptoms of depression, with features of this disease. Do not make the things so complicated. If the patient is not meeting the criteria, focus on the things which are more prominent. And if things are not very much distressing, there is no need to take or make the impression very much heavy. Maybe in the therapeutic treatment plan, we can include those. But if we include all those things in the impression part, it is actually going to confuse the overall treating team. And suppose the patient goes to other professional, it will be again further complicating for him. And it will the patient, it is the patient who is on the suffering end. So try to limit the symptoms and give a fewest diagnosis possible for the patient, because comorbidity is a rule in psychiatry. Nobody comes with a very clean diagnosis. You will always, almost 100% time, you will having certain comorbid conditions in psychiatry. So, but still you try to keep the diagnosis fewest as possible. Consider first disorders that have been present longer. So things which has been present for longer time, like if there is a history of alcohol dependence or abuse, anything, try to focus on those also. It's not mandatory that we have to go for a diagnosis of personality disorder. Use family history as a guide. So like in this case, what we discussed in just now, we see that there is a very complicated history of family history of substance use or abuse. Then the patient herself has a very past illness of childhood depression, further being diagnosed through bipolar, then schizoaffective. So it's a very complicated thing. So try to use those as a anchoring thing, as a reference, and comment on how actually the patient is presented in present in cross section. But definitely a longitudinal perspective is very much important. Now, talking about the use of measures, we all know there are n number of scales or rating scales or tests through which we are trying to diagnose or validate our own diagnosis. So in those MCMI or MMPI or NeoPI, semi-structured interviews like IPD, I hope I'm on time. IPD is there, then DSM-4, XS2 disorders, SCID2, and these were there. For if you talk about the projective test, we have the Rorschach test and the TAT. But again, in the current context, when we see that this category itself has been like now redundant. So now can we say that IPD, like the most very openly used or very commonly used screening tool for personality disorders, can we say that these are relevant now? I won't say that they are not relevant, but definitely they will give some idea about the basic constitution of the symptoms or the pathology set of symptoms which the patient is having. So this IPD was basically developed by the WHO in collaboration with US Drug Abuse and Mental Health Administration. And it is a very crisp screening tool and primarily used for the ICD-10 and DSM-3 R classification system, and now also for DSM-4. But now we have not forgot about DSM-4. Now we have DSM-5 TR to DSM-5 revised. So people might ask that whether they are relevant in current context or not, because now we are not talking about the categories. So maybe for DSM-5 IPDE can work, but what about ICD? So definitely we are not talking about the categories, but at least if we can get some idea about the features that we can, it can help in our diagnosis per se. But again, this also leads to the need of some new developments or some kind of a change in this screening tools, which is actually required. So there's a huge scope of development of tools for personality disorders in current context as such. And if you look at, they are very much widely applicable across the world in different languages. So I'm not going into these, the age criteria. Definitely, as I said in the beginning, it was not intended for the people of age 18, but nowadays we can also use up to say like the age of 15 also, and not appropriate for those with severe depression, psychosis, below normal intelligence, or substantial cognitive impairment. And its use with patients in remission from a chronic psychotic illness is somewhat problematic. So you need to be very much careful when you are doing using this screening tool for suspected personality disorder. So the limitations of these IPD is like it's definitely a self-reportive instrument and assumes that a person is capable of providing a valid description of disturbances in his personality. However, one may be unaware of some of his traits as such. So we need to be careful of those. I'm not detailing on this because I think it would be too long to detail on this. I'm skipping these slides. Yeah, this is important. Like when possible, some investigators may wish to postpone the assessment until the symptoms of other mental disorders have remitted. So in case the person is having some comorbid conditions, it is advisable to let this other symptoms to subside before going for a assessment on IPD. And in ordinary clinical practice, a family member or close friend is often used as an additional source of information to offset the limitations of the self-report method. So some of the other examiner biases are also there. Like we, as I mentioned earlier, we tend to give a random terminology of, okay, he is a case of PD. And the moment we see some signs of non-suicidal self-injurious behavior, some marks of self slashing or cutting on somebody's arms, अरे ये तो पक्का PD है. We do that, but we need to understand that engaging in non-suicidal self-injurious behavior is not always corroborative of personality disorder. It may be indicative of some other pathology. So we need to be very careful. Definitely, NSSI is highly comorbid with personality disorder, especially borderline personality disorder. But we need to be very much careful that there is no any other clinical history. Again, the pattern of the adolescent problem behaviors, the way adolescents or late adolescents behave in current generation, we might see a very gross similarity between the pattern of impulsivity, the judgment lacking, the impulsive behaviorness, the novelty seeking behavior, and the emotional regulation thing parts. They are very much common in adolescents. So it is a very people really get tempted to diagnose adolescents with features or traits of personality disorders. But we need to understand that what is actually normal for adolescents and what actually is and kind of a diagnosable condition. So for that, a very elaborate assessment and a very elaborate history taking is required. Simply on the basis of 1 or 2 interactions on the basis of self-reporting, it is not advisable to go for a diagnosis of personality disorder. So in conclusion, I would say that irrespective of the diagnostic impression, the purpose should be to understand the phenomenology of the symptoms. As I said, we need to look more into the dimensions of the person rather than in hurrying to reach the diagnosis or the category. Exact diagnosis may or may not be met. So it's not that you spend 3 or 4 sessions or 5 sessions and you're still struggling that, okay, what is the diagnosis of this person? You may or not meet even after a detailed history. That may be possible. So do not think that this is a failure for you. More important is that you understand that why these things are happening. It's not important that this person whether met a diagnosis or not. Comorbidities are very much common, and if any comorbidity is happening for a long time, try to give precedence to that. Comprehensive unbiased history is very much important. So you need to take the history in a very comprehensive way that will actually help you a lot in making the diagnosis. And even though, like, as I said, objective tests are very much important, but the findings of these tests should be used very carefully. So with these words, I would like to end my presentation. I hope it was legible to all the audience, and I'm open to any queries from the audience. Thank you so much.
Thank you, sir, for this informative session on personality disorders. Now, the floor is open to the question answers round. Anyone who has a question for sir, I will request you to come up to the stage and ask them through the mic, and he'll be open to answering the same.
Hello. Sir, I want to ask that in 2-3 sessions, how can we plan session dimensional approach because हमारे पास 2-3 सेशंस के लिए ही पेशेंट्स आते हैं इसमें हम डायमेंशन तो ऐसा any suggestions for that?
See, it's not that we didn't used to assess the patient in a dimensional approach earlier. The difference was that we focused more on reaching the diagnosis, and our major focus was that I need to tick the criteria that whether the patient is meeting the criteria for paranoid or schizoid or antisocial or something like that. But at the end, when we're trying to give therapy for the patient, at that point of time, the diagnosis is not important. At that point of time, we always try to understand that why the patient is engaging in that particular behavior. At that point of time, our goals are very specific. Say, like, for example, to make the patient more assertive. Say, for example, if the patient is having a diagnosis of dependent personality disorder, and we see in his overall history that patient is having issues with his assertiveness. So at that point of time, maybe one of my target goals for the therapy would be to make the patient more assertive. So that making the patient more assertive, that has nothing to do with the diagnosis of the patient. So this is the idea that we need to look more into the dimensions. So when we are taking a note of the history from how it has evolved across timeline, so we get a kind of a priority that what are the things which are actually bothering the patient. Now the difference in personality disorders and other condition is that many time patient is like may or may not be bothered that way. Like usually patient with personality disorder will not come to you on their own.
Yes.
So you need to make them understand that what are their behavioral patterns that is being dysfunctional to them. So in that way, when you engage the client in taking their overall history, you need to, by that point of time, 3 sessions are good enough to make a pattern of their overall behavioral pathology. What are the things they engage into? What are their pattern of emotional regulation? How they relate with other people? What is their idea of controlling their impulse? So that way you will get an idea that what are the main flaws of this person. Okay, so that way you can easily make that.
Thank you, sir.
Yeah.
Hello, sir.
You
सर आई हैव वन डाउट कि सर विद इन द क्लस्टर्स हम फिर डिमेंशनली हम कैसे इनको अंडरस्टैंड करेंगे कि वेदर इट्स कोमॉर्बिड विद नार्सिसिज्म और हिस्ट्रियोनिक सर थोड़ा एनलाइटन करें
As I said, ICD ने अभी जो 5 कैटेगरीज जो क्लस्टर दिए हैं अभी. Hello. Yeah. So yeah, it's okay. So what ICD has done, they have done away with the categories. They're not talking about the category of paranoid or schizoid or something. They're talking about the trait specifiers. That basically they're going for a single definition of personality disorders. The way they were saying in terms of ICD-10, PD ka, this is a single definition. So if you're meeting the criteria of personality disorder, you are a patient or individual with personality disorder. Now within this, what are the core features of yours? Of that, they're giving 5 specific subcategories that you might be matching criteria of dysthymic or avoidant or an ancastic, something like that. So there is not much major difference, but we are trying to see rather than a category, you're looking more in terms of the symptoms per se. Like you have symptoms more of anxious avoidant, or you are more about antisocial, or you are more about confined to yourself. The person may have a combination of 1 or 2. He or she may have combination of 2 and 3, 3 and 1, or maybe only 1. So it is a very broad in perspective. But इसका एक नुकसान ये भी है, people might be getting more confused also. So this is a negative output of this, that people might be getting confused and people will get a kind of a loose end. Initially what happened, people used to be trying to, in the attempt to match the criteria, they were trying to be more specific. But now it gives a free hand to the clinicians that, okay, I can say he is having symptoms of trait 1 also, trait 2 also, trait 3 also. Who is going to check actually? But eventually the idea is to destigmatize the overall thing. And rather than saying that, okay, you are having paranoid personality disorder or antisocial, you are having issues with, say, like trusting other people or not aligning with the societal norms or something like that. So that way we are going more in the dimension rather than giving a category actually. Okay, so as I said in one of my slides, that if you try to relate the clusters with the diagnosis, you can still correlate the clusters with the diagnosis.
Thank you, sir.
Yeah.
Any more questions?
Thank you, sir. With this, we come to the end of our question answer round. Thank you
Thank
so much for answering our queries and providing the information on personality disorders. With this, I would like to move towards concluding the session with a thank you note. I would like to thank our Honorable Pro-Chancellor, Vice-Chancellor, and all the authority and dignitaries for giving us this opportunity to get informed regarding personality disorders, issues, and challenges. I would like to thank our IBAS department HOI, Dr. Navratan sir, our HOD, Dr. Rajendra sir, and all the respective faculty members, department supportive staff, administration staff, IT, and media staff for their support in making this event a success. I would also like to extend my gratitude to all the participants from MPhil, PDCP, PGDRP, postgraduate, and undergraduate courses for their presence and active participation. With this note, I would like to officially conclude the event. Thank you all for coming. So please stay while we take a group photo with all the participants.
Thank you so much. Can I leave now?
No, sir, please wait for a final group photograph.
Okay.
थोड़ा सा हाँ ये that's वो सुन रहे हैं हम आओ फुल फोटो के लिए आओ लाइट नहीं जलाएंगे कोई जियो टैग वाला करवाना फोटो का Yes, please come, please. Yes.
सर ये है ना ब्लैक ये व्हाइट बोर्ड में पूरा इस तरह से बना लीजिए
व्हाइट पे बना दें
ये साइड
आओ यहाँ तक
मैं तो आया था सर, आया था फिर मैं वापस आ गया, पानी बहुत तेज बरस रहा है। हो गया तो बस हमारे यहाँ सेमिनार था वो भी हो गया। मैं बस आ रहा हूँ। आप सेमिनार हॉल में हूँ मैं यहीं पर।
अरे बैठो ना भाई सर आप लोग पूरे इसी फॉर्म में हैं
अच्छा
मैं आके देख गया था।
इसी रेंज में थोड़ा बढ़िया हो जाओ
हाँ सेमिनार हॉल
क्लस्टर हो जाओ हेलो
नहीं ये लोग बैठने को तो बैठने खड़े हो
हाँ
जो बैठे
अपन देखना सर आ रहे हैं ना पीछे से हाँ इस तरफ सबको नहीं बात करना है हाइड हो जाएगी ये हाइब्रिड मोड में है आगे आगे साइड होस्ट ना
सबको बोलिए
साइड ये सीधा भी देख रहे हैं Thank you, sir. Thank you so much.
Thank you so much, sir. Thank
We
you.
really feel obliged.
Sir, my pleasure, sir. And definitely we'll meet soon in person, sir. Thank you.
Ah, yes, sir. Thank
Thank
you.
you. Thank you. Yeah. Have a good day.
Meeting over.
Yeah.